Good morning to everyone. Welcome to the first podium presentation session of this Congress. The topic is proximal humerus fractures. I'm Ali Erşen from Turkey. I will try to moderate this session with my colleague, Dr. Ulrich Brunner from Germany. First, we will start with an introduction talk of Dr. Michael Scheibel about head split fractures of the humerus. Thank you.
Thank you. Good morning, everybody. So my task is to give you a brief overview on head split fractures of the proximal humerus. These are my disclosures. So most of what I'm going to tell you is written up in this publication that is open access. So if you want to have a look at it. We're talking about head split fractures, which is a fracture of the articular cartilage, including the underlying bone. And the question is always how much needs to be involved of the articular cartilage in order to call such a fracture a head split fracture. So in the literature, it would say about 20%. I don't know if this is really true. If you have, let's say, an 18% avulsion or impaction fracture, and this is biomechanically relevant, probably we should also call this a head split fracture. So I think biomechanical relevance is probably more important. So we came up with this classification after looking at our cases. We identified 4 fracture patterns, and I will briefly show you how they look like. So a type 1 head split is a posterior split. So you basically see the major aspect of the articular head being anteriorly, and the split is more posteriorly, and the articular surface is still attached to the greater tuberosity. So this is what we call a type 1 posterior split. On the opposite, there is the anterior split. So you have the major part of the humeral head being posteriorly. The split is anterior, and there is adjacent cartilage to the lesser tuberosity. Then you have the so-called type 3, a free-floating impaction kind of situation, where you have kind of a double split, and usually these are very difficult to treat. Sometimes they can be twisted, those impaction situations, and this is what we call a type 3. And a type 4 is a comminuted fracture where most of the head is fractured in a comminuted situation with or without comminution of the greater and lesser tuberosity. So how do we detect this? You do a true AP radiograph. You see the so-called pelican sign, which is the extension of the humeral head from the greater tuberosity. So that's for the type 1. And if you see it on the axillary view, you can also appreciate the extension of the articular surface. That's usually indicative for a type 2 head split. Obviously, we do a 3D CT evaluation to see where the head split really goes, and this is an implication also how you approach this surgically, if you need to open the rotator interval, if you might need to take down part of the subscapularis tendon. So I think a 3D CT is mandatory in those head split situations. So the problem of head split, number 1, we believe that if you have a head split, this is a disruption of the blood supply of the articular fragments. At least it has been proposed. And of course, it's difficult to reduce those fragments. So it's the combination of difficulty of reduction and blood supply might lead to more complication. This was the reason why in former days the indication for shoulder arthroplasty was given if there was a head split fracture, with one exception, the very young patients where an open reduction internal fixation would have been attempted. But is it really true that a head split goes along with decreased vascularity? If you look at Ralph Hurtel's paper, head split fractures were only shown to have moderate to bad being predictors for ischemia, meaning that probably the head split does not really mean ischemia and does not really mean necrosis. So we should really think about Ralph Hurtel's criteria if we have a head split fracture and look more at length of metaphyseal extension, integrity of the medial hinge, etc. So how do we treat head split fractures? This is a 49-year-old patient who had a type 1 head split fracture. You see on the 3D CT, minimal displaced. So I think everyone would go for non-operative treatment. We did non-operative treatment, and at 3 years follow-up, you see the fracture is healed, there is no arthritis, and the patient had a very good functional result and even back to his yoga activities at 3 years follow-up. A little bit more difficult, also type 1 posterior split in a 59-year-old female, very active lady, and she decided to go also for non-operative treatment. You see the split is again posteriorly. There is more step-off compared to the patient you have seen before. So again, due to the wish of the patient, she was treated non-operatively, and what you see at 1 year follow-up, there is remodeling of the split. There's also no arthritis yet, also we don't really know how this looks like, and her function is pretty good at 1 year, and I doubt if you would have operated on this patient that the function would be better. So at the moment, we don't really know what the true indications are for head split. Probably the posterior head splits are more forgiving than the anterior splits, and we should consider in those patients really a non-operative approach. This is an anterior split in a 48-year-old, and you will see here, you can see on the AP view also the pelican sign related to the lesser tuberosity, and you see it even better if you look on the 2D CT. And probably this split is not 20%, but of course it's biomechanically relevant, so you need to treat this articular cartilage fracture, and what we usually do is an open reduction internal fixation. We elevate the head. We advance K-wires from the shaft to the head. We control the reduction also on the axillary plane. And if, like in this case, there is a split, we usually place an AP screw to compress the split and then put on the plate. And this is our approach in most of the anterior split, head split fracture situation. This was the patient's at 2 year follow-up. That's his X-ray. One study I would like to bring up here is published by Ben Ockert, where they looked at patients where they just did a deltopectoral approach and reconstructed the head split without opening the glenohumeral joint, compared to a second group where they did a rotator interval approach in addition to the deltopectoral approach, and basically under direct visualization reduced the head split. And you see with the rotator interval approach, the results were better in terms of reduction, and also the constant score was better in this particular group. So you should consider this additional exposure, maybe also taking down upper part of the subscapular if it's needed to get a good reduction. Because complications do occur, and if complications occur, they're usually related to malreduction and then malunion, like Bernhard Jost has shown in his study, and this is a typical case where it has been malreduced, and then patient went on to hemiarthroplasty, and usually the results of hemiarthroplasty in those situations is not as good as you get a perfect reduction and good healing of a proximal humeral head split fracture. We also looked at our cases. Also in our series, the complication rate was pretty high, and it was clear that if patients went on for revision after a failed head split treatment, the constant score is significantly lower compared to patients without any revision. Then the question, is there for head split fractures an indication for hemiarthroplasty? Everyone, you know, is avoiding hemiarthroplasty nowadays for proximal humeral fractures. But I show you this case. It was a 73-year-old lady we treated, I don't know, 15 years ago maybe, with this head split. You see robust greater and lesser tuberosity. And I put in this hemiarthroplasty at 2 years, and she was doing very well. And there's a study, and that's the reason why I showed you this case, that has looked at the outcome of head split versus control group of 3- and 4-part fractures. And they found that hemiarthroplasty in head split fracture situation gives better functional outcome compared to if you use it in typical 3- and 4-part fractures, and the complication rate was also lower. And the group concluded that in head split situation, you usually have obviously a fracture of the head, but you have a more robust quality of the greater and lesser tuberosity, and this might go along with a better healing of the greater and lesser tuberosity if you do a hemiarthroplasty. So probably do not forget hemiarthroplasty in the setting of head splits with robust greater tuberosities where you don't want to do OREF or reverse. Of course, in comminuted fractures, and that's the last case, reverse shoulder arthroplasty is the way to go. This is a lady with a 2-year follow-up with quite good functional results. And together with Uli Brunner, we looked at our head split fractures treated with reverse in a prospective cohort with pretty good functional outcome. And we were even able to compare type 1 and type 4 head split in terms of functional outcome. And you see, even in the reverse, if you have situations with robust greater tuberosities, the functional results, like in the type 1, are better than in type 4. So to summarize, still they are challenging. Consider 3D CT evaluation. Look at the 4 basic fracture pattern because they also guide you how you approach them surgically. Head split is not really ischemia and does not really mean necrosis. Consider the rotator interval approach if you need it to better visualize the fracture situation. Maybe consider also hemiarthroplasty if as still one indication in proximal humeral fractures, but in comminuted situation, the reverse arthroplasty is the treatment of choice. And I thank you very much for your attention.
Thank you, Marcus. I think we have a little bit time for discussion. If there is any question or comment.
Marcus, I have a question. You're pointing out the position of the fracture, but we know that we always look at the step, which is maybe locking against the glenoid. And these type 1 and type 2 fractures you were showing there had only a small step off, and the third case had a big step off. So I want to ask, does the amount of the step off plays any role in your classification?
Yeah, we have not included the amount of step off or quantified the amount of step off because we don't really know at the moment what you should do. Personally, I believe the patients can cope better a posterior split with a step off, and the step off can be even larger if it's a posterior split compared to an anterior split, because if we look at neglected head split or patients who have had an OREF for anterior split with a plate and they are mal-reduced, the anterior split is usually causing more problem than the posterior split. So I don't know, I cannot give you an answer of how to quantify the step off, but I think in order to evaluate this, we need to see more patients treated non-operatively and then find out what the way to go.
There is one question.
Thank you, Marcus, for the presentation and for giving life to these type of fractures. I would like to ask something about the age. Is there any correlation between your types and the age? Because you show some types not very bad displays for young people, and for the older people, you show the type 4. So is there any type of correlation with the comminution?
Yeah, the type 4 tend to be a little bit older compared to the ones with robust greater and lesser tuberosities, but there was no statistically significant difference.
Okay.
Thank you, Marcus.
Thank you.
I think we can go on with the podium presentations.
I will.
Yeah.
We will have the next presentation from Casa Masnou from Spain on the question. Yes, please. With the question whether we need an X-ray control after 1 week. Very important question.
Yes. Good morning. Good morning. In the conservative treatment of proximal humeral fracture, it's a common practice to perform a 1-week X-ray control to detect further displacements of the fracture that may change to a surgical treatment. Only one published study evaluated the need of periodic imaging studies in patients with non-displaced fractures treated conservatively, and with no evidence that it results in a change of treatment, and it concluded that it is unnecessary in most patients. To date, no studies have been performed in displaced fractures. So the aim of our study was to evaluate the need for 1 week X-ray control in patients with proximal humeral fractures treated conservatively for all fracture types, displaced and non-displaced. We hypothesized that 1 week control would not provide any advantage in the treatment of these fractures. We designed a prospective, randomized, multicentric study involving 4 centers, including patients from February to November 2021. We included patients aged 18 to 85 years old with an acute proximal humeral fracture, less than 1 week, candidates to conservative treatment, and with no previous shoulder pathology. And we excluded patients with dementia, unable to participate in a rehabilitation program, and candidates for surgery. The treatment decision was undertaken in each center under the shoulder surgeon decision, considering age, comorbidities, functional demand, and the near fracture pattern according to an X-ray and a CT scan that were performed the same day of the fracture. We aim to include 90 patients, 45 in each group, to detect a minimal clinical important difference of minimum 10 points in the constant score. 143 were randomized into groups, group 1 with a 1 week X-ray control and group 2 without. All patients were immobilized with an sling for 3 weeks and then followed the same rehabilitation program. Pain was assessed with a BAS scale at 1 week, 3 weeks, 3 months, and 6 months. And the functional outcomes were assessed with a constant score and the simple shoulder test at 6 months and 1 year. Radiologically, patients were followed up with simple X-ray at 1 week for group 1 and for both groups at 3 months, 6 months, and 1 year. As complications, we assessed non-union, stiffness, avascular necrosis of the humeral head, and the need for surgical treatment. And we also recorded the need for 1 week X-ray control in patients in group 2. Let's move on to the results. We had 16% of loss to follow-up, less than the 20% initially estimated, most of the cases due to unknown reasons. So at the end of follow-up, we had 120 patients, 66 in group 1 and 54 in group 2. Both groups were comparable in terms of age, gender, laterality, dominance, and fracture type, without significant differences between them. And regarding the fracture type, we had 36% of patients with a one-part fracture, and it's important to highlight that we have 64% of the patients with the displaced fractures according to the NIR classification. Regarding pain, no statistically significant differences were noted between both groups at any point of follow-up. And in the functional outcomes, as you can observe, we didn't find any differences between groups in the constant score, nor in the simple shoulder test at 6 months. And as you can observe, the same result was obtained at 1 year, with 70 points in the constant score for both groups. Moreover, there were no differences in the constant score subscales between the groups. As complications, we recorded 5.6% without differences between groups, involving 8 patients, 5 patients in group 1 due to stiffness and avascular necrosis of the humeral head. In this group, 2 patients required surgery, 1 for avascular necrosis that was treated with reverse shoulder prosthesis, and 1 due to stiffness, treated with an arthroscopic release. And in group 2, 3 patients had complications, 2 cases of stiffness and 1 non-union. None patient in this group required surgery, and in this group, 1 patient received a 1 week X-ray control without changes in the treatment protocol and without complications for this patient. So, according to our results, we can conclude that a 1 week control X-ray is not necessary in proximal humeral fractures treated conservatively. Thank you.
Thank you very much for this interesting paper. Are there questions from the podium, from the floor? Maybe I didn't get the point. We do an X-ray after 1 week because we think there's a displacement, and then we change the treatment protocol. How many patients have you had where the treatment protocol was changed?
No patient changed the treatment protocol. So the question is that we usually order a 1 week control but our purpose was to find evidence about if this X-ray changes the treatment or has influence in the results. And we have found that if we do or if we don't do a one-week control, what happened radiologically doesn't seem to have influence or to be enough relevant because we don't find consequences in the results.
Have you realized the number of fractures that have further displaced?
No, we have not assessed the radiological displacement because we thought that if the radiological displacement was relevant, it would be reflected in the results. Because the point that matters to the patient is the clinical results. So if what happens in the X-ray does not seem to have consequences because no patient changed to a surgical treatment, the functional results were the same and the complications were the same. And only 2 patients had surgery at the end and were patients in group 1. They had the chance to change because they had a one-week follow-up. And the surgery was not due to a surgical displacement, it was for other reasons. So.
I have also a question. It's a great effort to do a randomized controlled study. So what is the disadvantage of having an X-ray on the first week? Except a small amount of radiation exposure. So why it's so big effort?
We can save visits to the patient. We can avoid complementary explorations, and we can save radiation in a pathology that is increasing over years. So it's just to find the evidence that why we do the things, because we usually do things that we don't have evidence that why we are doing these actions in our practice.
Thank you. Thank you.
Thank you.
So the next speaker is Dr. Speck. He will speak about his study about the classification of proximal humerus fractures.
Right. Good morning, everyone. Thanks for this opportunity to present our research here. Today I want to discuss the role of convolutional neural networks to detect proximal humerus fractures and also to classify them. My name is Reinier Speck. I'm a researcher at Flinders University and the University of Groningen and an orthopedic resident at the OVG Amsterdam. I'd like to acknowledge all the co-authors and also the Machine Learning Consortium and all the institutions who were affiliated with this study. So the problem with classifying proximal humerus fractures is there is a very low inter-observer reliability. So some surgeon may say it's a 3-part fracture, other one may say it's a 4-part fracture. And even with the introduction of 3D printed models with 3D CT scans, we're not able to improve it. And that's an issue because it doesn't really contribute to the ongoing discussion on which patients to select for surgical treatment because we can't really describe them well, we can't really compare our patients well in the literature. So that's causing a lot of frustration. So we set out and undertook this study, so we basically wanted to create an automated computer algorithm and convolutional neural network which will be able to automatically identify fractures, proximal humerus fractures on plain radiographs, and also classification. So basically, our intention was to outsource the classification task to the computer. But a few aims. So the first aim was to simply detect whether there was a fracture or not. So fracture versus healthy shoulder. And then in the second aim, we looked to classify the fracture. So we had the near classification. We simplified it to non to minimally displaced fractures, to the 2-part fractures, to the multi-part fractures, which include the 3- and the 4-part fractures, and then also the glenohumeral dislocation fractures. So what we do, we collected as many radiographs and CT scans as possible from South Australia. So the main inclusion criteria was a CT scan because that served as a reference standard for our classification and for the fractures. And every CT, every radiograph we labeled was done by multiple assessors, so it was always done in consensus agreement. So we had, amongst others, multiple researchers and 7 orthopedic surgeons involved in the team to do our labeling work. So how did it work? So how we set up the study is basically, the first step, we had our 3D CT scan. We assessed that for simple fracture or no fracture. Then we classified it to the classification I just mentioned, and we did it by multiple assessors. So we had a consensus agreement, and that was the ground truth. That ground truth was assigned to our X-ray, and then in the next step, we actually put a bounding box. So we upload it into label box, and that's where you can manually put a box around the fracture area. So that helped us to let the algorithm know where to look at. So we trained the algorithm. That was the first step. So we had 803 patients, of which, most of them were healthy shoulders, 350 fractures. Then we had our algorithm. That was done on South Australian data, and then we internally validated it on a subset of that. So there was a random set of 244 shoulders. And then after that, we externally validated it on data from 2 Dutch hospitals. That was done on 227 patients. So the results. So we found an overall accuracy of 94% for detecting fractures on plain radiographs for the internal validation group. So that was actually quite good. And also for the external validation, it was also quite good. It wasn't really much difference, so it was 92%. But when we looked at the classification, it was actually quite poor. So the internal validation was 78%, and when we looked at the external validation, so the validation on the 2 Dutch hospitals, that was 75%. So that wasn't really what we were looking for, unfortunately. A few of the results. So on the left side, you see in red, that was the ground truth. So we assigned a multi-part fracture. So this proximal humerus fracture was a multi-part fracture. And you see in the green box that the algorithm predicted basically the same. So even though it doesn't work perfectly, it was still pretty cool to see that we were actually able to get this algorithm to work in some cases. So we still think there's a lot of potential. So up for discussion, the fracture detection, that's on par with human evaluation. Classification is not. We think for the future we should continue describing our fracture patterns with fracture characteristics and set up studies for this as well. We did this X-rays with primary input, the radiographs, but I think the next step will be to use the CT scan as the primary input. And we definitely would like to encourage all the researchers to keep on doing research on AI, because it can handle a lot of data. It is efficient. It's rapid, and it can actually help with objective decision making. So in conclusion, the CNN we developed proficiently ruled out proximal humerus fractures on radiographs, but the classification diagnostic parameters are insufficient for clinical implementation. And we can learn from this is that diagnostic performance decreases when tasks become more complex. Thanks for your attention.
Thank you. As you mentioned in your first slide, the most difficult part is to differentiate between 3-part and 4-part fracture. So even your system doesn't differentiate it and call it multi-part.
Yes, that's correct. Yeah. We tried to simplify it because we had to score everything, so we wanted to keep our inter-observer reliability as good as possible. Yeah.
Are there questions from the floor? What is your idea about discrimination for the next step? You said our discrimination criteria are poor, but so far we have done this for many years, and I think non-displaced and displaced is a very simple one. If you say 1 centimeter or 45 degrees, even that was not possible with a computer.
Well, if we, yeah, well, so that's a good question. So what the computer was struggling with mostly was that it wasn't able to distinguish the two-part fractures from the multi-part fractures. That was actually the biggest pitfall for the algorithm. And I think the none to minimally displaced, I don't really know that on the top of my head, but that category was a little bit better. So basically the low accuracy was, yeah, one of the most contributing factors was two-part versus multi-part fractures.
But
yeah.
that corresponds to our clinical experience. Even
Yes.
that for us is difficult to say where are the fracture lines
Yeah.
or not.
Yeah, definitely, but I think still, if you look at it overall, because we also trained the algorithm to have like one category of healthy shoulders, so that actually, yeah, pumped up the accuracy a little bit. I think if you look at the overall accuracy, I think it's still too low, like we are experiencing in the clinical practice as well.
Thank you. Thank you, Dr. Speck.
Thank you.
Yeah, we go on. Now, it's a pleasure to have a speaker from Turkey. Yeah. Mr. Kai Makoglu, comparison on short uncemented metaphysical.
No, it's not that.
Huh? Oh yeah, preliminary study on integrating CT MRI, so a new kind of MRI study.
So thank you. It's an honor to be here. I'm going to present our preliminary study of integrating Zero-TE MRI in proximal humerus fractures, which we believe that someday it may combine CT and MRI in just one imaging technique. So our patient numbers has increased, so I would like to present our study with our current results. So what is zero-time echo MRI? So the audience would not be familiar with this technique. So it's a new imaging technique that produces images similar to CT with MRI, and it uses very short T2 signals in less than 1 millisecond from the bony matrix. And this results with excellent contrast between cortical bone and soft tissues, similar to CT. So the biggest advantage of this technique that it does not have any radiation, and with other sequences like T2 or T1, you can easily get soft tissue assessment as your patient is already in an MRI device. And you can also evaluate the zero-TE images in different planes with the help of MPR. So in the shoulder, there are only few studies that evaluated morphometric analysis like glenoid defects measurements and glenoid track assessments. So our study came with the idea of what if we use it in proximal humerus fractures, because most of the time we use CT for further evaluation of proximal humerus fractures, and we wanted to show the validation of zero-TE MRI compared to CT. And so far we evaluated 30 patients, and we sent the patients who had already a CT scan in the ER with the diagnosis of proximal humerus fractures to the zero-TE MRI within a maximum interval of 1 week. And we excluded some patients with claustrophobia, history of shoulder surgery, and non-MRI compatible implants. So 2 reviewers reviewed CT and MRI images independently under the supervision of a musculoskeletal radiologist. And the reviewers were blinded to clinical information except the age of the patients and other imaging modalities like X-ray. So we left a 1 month interval between CT and zero-TE MRI evaluation. We analyzed the images in terms of fracture and displacement detection capability, and we classified the fractures according to Near classification system. For 3 and 4 part fractures, we compared the Hertel criteria, and we also observed and noted the soft tissue injuries like rotator cuff tears or annularbral damage, and we also compared the reviewer's decision on treatment plan. We accepted CT as a gold standard imaging technique, and we compared the zero-TE MRI images with CT in terms of inter-observer reliability. We had 16 male patients and 14 female patients, and our mean age was 59.4. So we found moderate to good agreement in most of the CT parameters between the 2 observers, and we found moderate to good agreement in most of the zero-TE parameters between 2 observers. And if we compare CT and Zero-TE MRI, despite the Hertel criteria, we found moderate to good agreement in fracture detection, fracture fragment detection, and displacement. And a statistically significant good level of agreement was obtained between CT and MRI in terms of the near fracture classification. We also found moderate agreement between the treatment decision of two reviewers. And there was a good agreement between the measurements of the fractured major tubercle in two different places, so it was a quantitative measurement. Well, we observed in this series 4 traumatic cuff tears, 2 of them were massive, and 5 labrum tears and 7 partial biceps tears in routine MRI sequences. Here you can see some examples. On the right side, you can see, on the left side, sorry, you can see a massive acute tear of the rotator cuff in a near 3-part fracture. You can see the tendon kinking sign, and if you plan a hemiarthroplasty, and it will definitely fail. And on the right side, you can see both the displaced tuberculum on zero-TE sequences, and you get a clear view of a traumatic tear that CT could barely show you, and the conservative treatment will carry high risk of failure. You can see 2 examples of both imaging techniques. Above you can see the CT scan images, and below you can see the similar sequences of zero-TE MRI. Only few studies evaluated MRI with acute proximal humerus fractures and found high rates of soft tissue injury. For example, one study from USA reported a 9% of full thickness tear in greater tuberosity fractures, which is a very high rate. So we have found a good inter-observer agreement of zero-TE MRI compared to CT, and zero-TE MRI technique is excellent in detecting fracture fragments and displacement. Of course, our inter-observer agreement decreased in near classification, as you all know, even with gold standard CT, it's reported moderate to good agreement in the literature. And low patient numbers avoided the agreement in Hertel criteria in our 3- and 4-part fractures. So we had low numbers of patients, and demographic characteristics of the patients were inconsistent. And of course, this is just a radiological study. We had no clinical follow-up. And other limitations of the zero-TE MRI is that it's not available in many centers. So the resolution is still inferior compared to CT, and some patients are not compatible to MRI, of course. So in conclusion, zero-TE MRI has promising reliability in defining fracture patterns. So it may be a good alternative to CT in the future. It limits the radiation exposure in trauma patients, and with improvements in resolution, we may use it even in preoperative planning softwares in the future. And instant soft tissue knowledge with fracture characterization may help for a better outcome. We may modify our classification according to soft tissue injuries, and clinical studies with more patient numbers are needed for further validation. Thank you.
Thank you. Thank you very much. Interesting, fascinating topic and paper. Are there questions from the floor?
There is one question.
Thank you very much for the presentation. I would like to ask you, how long does it take to do this type of MRI?
Well, actually, zero-TE MRI lasts only 3 minutes. If you don't want to see the soft tissue, for example, you can send the patient to zero-TE MRI, and it's maybe 1 or 2 minutes longer than CT, and without contrast.
So that's good, because sometimes when you put the patient lying, they are complaining about the pain and they are moving. And that's why my concern about the good pictures you can take with this type of injury.
Well, yeah, we had some difficulties, for example, in fracture dislocation patients. We had to exclude them, most of the fracture dislocation patients, because with that fracture dislocation, the patients were incompatible in MRI device, but most of the time we had good success in it.
Yeah, Ofa, please.
Very nice presentation. And I would like to ask, do you get different views? Can you get different angles in this Zero-TE MRI?
Yes, actually, you can do a multiplanar reconstruction. You can see from axial, coronal, or sagittal sequences. Well, you can even do a 3D reconstruction, but it's still very time-consuming for radiologists. So it needs a little bit development, I think.
Very nice, thank you.
Thank you.
My last question is, can we do these time-zero MRI with any machine, or is it a specific
Actually,
software, or what?
Well, it's a kind of software. You can do it with 1.5 Tesla or 3 Tesla, but 3 Tesla is recommended. And only, to my knowledge, only General Electric and Siemens has this feature. So if you have that kind of MRI, and if your hospital buys the software, you just get instant Zero-TE sequences.
Okay, thank you. Thank you.
Thank you, Mehmet, for your presentation. Now we go on with the next speaker from Italy, Dr. Ippolito, will speak about his study about 2-year follow-up of uncemented metaphyseal stems.
Hello, thank you for invitation. Invitation. I will talk about comparison of short uncemented stem and long stem for proximal humeral fracture. Epidemiology about proximal humeral fracture. These are 6% of all fracture and the maximum incidence between 60 and 19. For the algorithm of treatment depends by bone quality, experience of surgeon, and pattern of fracture. In the 15%, the high risk of stenosis say us to perform an HEMI or reverse shoulder arthroplasty. Stem fixation can be done or with cement or cementless. Cement or cementless, who wins? The bet is opened and depends by operative technique and complication rate, as infection, dislocation, loosening, fracture. In literature, both are valid option and probably win cemented for any reason. But why uncemented is better? Probably because surgeon tends to minimize complication, operative cost, and probably operative time. Cement is better. One reason and one topic is stress shielding and osteolysis, and because in cementless design is necessary two oversights. Cement is better probably for tuberosity because, as in this case, short stem with a combination between resorption of tuberosity and stress shielding. Tuberosity healing give better stability, no loosening, and minor risk of reoperation. In our study, tuberosity resorption give lower results. But on the contrary, Giuseppe Porcellini published this paper that tuberosity healing is not decisive for low-demanding patients. Revision rates are increasing in last days as pre-prosthetic fracture, especially in press-fit humeral stem, as intraoperative fracture or late pre-prosthetic fracture caused by stress shielding or stress shielding in osteoarthritis stem because is oversized. Short stem or long stem, who wins? The most common practice is long stem or standard stem. In last years, Raffaele Garofalo published this good results with metaphyseal stem with cerclage for proximal humeral fracture. Short stem is commonly used in osteoarthritis with comparable results, also in terms of radiographic loosening, and the radiographic results are equivalent. Why short stem is better for bone stock preservation and for non-asymmetric reaming, and easier osteosynthesis during fracture. While long stem is better for solid literature and better primer stability. A aim of our study is to evaluate if short stem, our stem, may have comparable clinical, functional, and radiological results than long stem in reverse shoulder arthroplasty for fracture. In our study published last August, we studied 125 patients with 3 or 4 fragment fracture between December and 22 in 2 centers in Rome. 53 with short stem, 72 for long stem. Population, 2 groups were very similar for age, sex, comorbidity, and pattern of fracture. At 2 years, range of motion in terms of degrees was very similar, with no statistical difference. Also, clinical outcome in constant score, DASH, and SS score. Radiographical change were studied by classification system and servo for scapular notching. Results are 2 years, very similar in both groups, no loosening of the prosthesis in both groups, and no revision surgery was needed in both groups. Limitation of our study, because it's a randomized study, a follow-up is relatively short, but 2 years from the start of the study. Reverse shoulder arthroplasty were not performed by the same surgeon, but by 5 surgeons. And in conclusion, the use of short stem can be considered safe, effective, and a valid option for reverse shoulder arthroplasty for fracture. Surgeons are moving on cementless and short stem, despite literature is not insufficient in fracture. In our hands, short stem should be considered a procedure of choice in patients with good bone quality, and under 17. But it's essential to evaluate the clinical history. Our results are very encouraging in this study in comparison with long stem, but I think that it's very necessary to include in randomized study and clinical trial to enhance the level of evidence. My choice today is this for fracture, short stem with the diaphyseal fit, inlay with augmented glenoid and angled superior lateralization of 7 degrees. Who wins? I don't know. I invite you in La Mezzia Terme in Italy in International Congress meeting Shoulder 360.
Thank you. Is there any question from the floor? Yes, please.
No. In our study, short stem and long stem were not cemented. The comparison was between uncemented short stem and cemented long stem. And the results are very, very similar. It's true.
So in your study, the long stems are also not cemented, uncemented?
Uncemented, yeah. Yes.
Okay.
Thank you.
Thank you. So we have the chance to go on for the last one. Mrs. Stringfellow from Great Britain. A conservative or reverse outcome of conservative versus reverse RSA in proximal humeral fractures, please.
Good morning, my name is Tom Stringfellow. I'm a trauma orthopaedic registrar from London, UK. I'm going to present the results from our study, Outcomes of Conservative versus Reverse Total Shoulder Replacement of 3- and 4-part proximal humerus fractures, and this was in patients over the age of 60 years. This study was done at Barnet and Chase Farm Hospital, part of the Royal Free London NHS Foundation Trust. So at present, there are currently mixed conclusions from cohort studies and small randomized controlled trials in this area, and previous retrospective series are small in number. Therefore, at present, shared decision-making based on patient factors and fracture patterns is the current best practice of care. So despite this equipoise, there's an increasing number of reverse shoulder replacements being performed yearly in the UK, according to our national registry data. Last year, there were over 2,500 reverse shoulder arthroplasties performed for fractures in the UK. So our study was a retrospective, single-centre, single-surgeon review of all patients greater than 60 years of age, presenting with 3- or 4-part proximal humerus fractures. The radiographic assessment for inclusion was by 2 senior subspecialty surgeons, and this was based on near classification, based on presenting radiographs and CT scans were performed. We recorded complications and PROMs routinely in our outpatient clinics, and where there were any gaps, we contacted patients to ascertain PROMs and any complications that were sustained. We excluded all patients with ipsilateral upper limb injuries or nerve injuries. We did include some head split fracture patterns. So the PROMs we collected are listed on this slide, and our main primary outcome measure was the Oxford Shoulder Score at 2 years post-injury or shoulder replacement. We used minimal clinically important difference and patient-acceptable symptomatic state thresholds for this work, and these were both literature-based. So we used 75% for the SSV, and for the other PROMs, these are listed on the slide here. We reviewed radiographs and clinical notes to record complication, reoperation, and reintervention. And all surgery in our series was performed via a transdeltoid approach by a single surgeon, which was a senior author. We included 99 patients, 64 in the non-op and 35 in the reverse shoulder arthroplasty group. It was in keeping with the literature. Most of our patients were female and elderly, with a mean age of 71 in the non-operative and 72 in the reverse group. Whilst there was a difference in the overall numbers between the two groups, as expected, these were well matched for age and gender. Due to frailty and patient comorbidity in our elderly population, the non-operative group was larger than the reverse shoulder arthroplasty group. So at a mean follow-up of 35 months and a minimum follow-up of 24 months, the Oxford Shoulder Score, SSV, parts of the SSV were all higher in the reverse total shoulder arthroplasty compared with the conservatively managed group. Quick dash was significantly lower and therefore superior in the reverse total shoulder arthroplasty group. And there were no significant differences in the VAS pain scores between the two groups. There was a significant difference in the number of patients who reached the pass threshold of 75% for the SSV score, again favoring reverse total shoulder arthroplasty. The differences in the mean scores are summarized in this table. Particularly the Oxford Shoulder Score reached the MCID of 6 points. And these values are at a mean time frame of 35 months average post-intervention. And all of the MCID and pass thresholds were reached. Following review of records and radiographs, we were able to ascertain complication rates for both the two groups. There was a greater than 10% difference between the two for raw complications. Particularly in the non-operative group, stiffness was a huge problem, and this really affected patients' activities of daily living and functioning. We also observed a higher mortality in the non-operative group, 15%, compared with 1.5% for the reverse total shoulder arthroplasty, but this is likely due to selection bias, frailty, and increased comorbidity in those not fit for initial surgery. So both the strength and the limitation of the study is that this is a single surgeon, single center series. However, this did ensure a consistent operative technique and a consistent post-operative protocol. Our study has a long follow-up period and is the largest reported series to date, comparing directly non-operative treatment with reverse shoulder arthroplasty in patients aged 60 years or over. Elderly, frail patients and low performance status were largely managed non-operatively and hence were rarely fit for surgery for malunion, and therefore looking at PROMs in both groups rather than reoperation is the way to go here. We saw a high incidence of ultrasound-guided injections for stiffness in our non-operative group, and this indicated the significant impact on their function that they sustained. Further work to identify prognostic factors would be useful, and this would help to stratify patients and counsel them better regarding their treatment options for these fractures. Furthermore, the PROFA-2 trial will use the Oxford Shoulder Score at 2 years post-injury as a primary outcome, as we did in our study, and this will make a valuable contribution to the evidence base for elderly proximal humerus fracture management. So in summary, our study comprised 99 patients and showed superior results of reverse total shoulder arthroplasty compared with non-operative treatment for 3 or 4-part fractures in patients aged 60 years or over. We used PROMs at a minimum of 2 years to demonstrate this, and the minimum clinically important difference in pass thresholds were reached for all scores, apart from VAS pain. There was an overall higher rate of reintervention in the conservative group and a high rate of stiffness limiting activities of daily living, which had a negative impact on patients' level of function. Thank you very much. I'm happy to take questions.
Thank you very much. Interesting paper so far. Are there questions from the floor? This is very important. The first paper against the argument that we are spending too much money for the reverse. Yeah?
I think there's one question.
There's a question, yeah.
So there are several papers talking about more than 80 years old and more than 70 years old, that it's a lot better it's a prospective randomized studies, that they tell us that there's no difference between those. And you are telling us with a retrospective one, older than 60 years old, in a 2 years follow-up, that we have to operate them. So how can you say or conclude that? Because there are several randomized control trials telling the difference is not that big.
So, yeah, as you mentioned, there are various studies of various age cutoffs for this group. I think the key message from this paper is that the PROMs are superior in the reverse total shoulder arthroplasty group. Obviously, with this being a single surgeon, single center series, the results are not directly transferable to everyone's practice. This represents our unit, and we see a particularly high proportion of elderly, frail patients. So it's not an RCT, it is a single surgeon series with patient-reported outcome measures. I think there's still not a definitive answer here, and within our particular health system, within the NHS, we're going to have an answer soon with a large randomized control trial, PROFA-2, and that will look at, obviously, patients aged 65 years or over and include HEMI as well as a treatment choice. So I don't want the key message of this paper to be that we should be operating on everyone because the PROMs are better, but I appreciate the question. Thank you.
Thank you.
Since the study is retrospective, could it be possible that low-demanding, in poor condition patients are selected as conservative, and the more active ones who will participate more physical therapy and etc. is the reverse group?
Definitely. I agree with that comment. I think certainly there's some work to do to identify factors, maybe comorbidities and frailty scores, etc., to really stratify those patients that we should be almost selecting for operative management, because there are definitely a group that will do better. We know that. So I agree. I think, all studies like this are prone to selection bias. Certainly, I acknowledge that within our patient population, we have a very elderly local population within our particular area of London. So I take that point entirely. Yeah, thank you.
Okay, thank you very much to all the speakers for good papers, excellent papers, and good discussion, so we can finish in time. Have a good Congress. Thank you.
Thank you.